One of the common fracture around the base of the metacarpal of the hand is the most common pattern is the extra-articular EP basal fractures. We know the anatomy, like the CMC joint is a saddle shape joint, and the multiple muscles are there which is balancing over the over the carpal. The metacarpal is getting balanced. Number of ligaments are there. One of the important ligament, the volar oblique ligament, which spans the tuberosity of the trapezium to the volar edge of the first metacarpal. There is a limited axial rotation. The mechanism of the injury is the axial force applied to the thumb in the flexion. There is an imperfect reduction increases the joint contract pressure, which will lead to the early arthritic changes. The imaging is important. You have to get a true AP view, true lateral view, oblique traction view, or sometimes even the CT is indicated to make sure what you are dealing with what kind of fracture you are dealing with. Classification includes the extra-articular to the intra-articular fractures, and various kind of combination has to be noticed before putting a screw or plate for the fixation purpose. Some of the example I would like to show here is one of the basal fracture with an intra-articular rather than extra-articular fracture here. We got a plain X-ray followed by the CT scan where one can see the fracture. Here one can definitely reduce it very well by a closed means, but stabilization is very, very difficult by a closed means. One may require to put the wire, which is one of the easily available implant, and one can easily perform it under the image intensification. We have opted this by putting a mesh plate around the base of the metacarpal, where one can safely place the plate underneath the extensor pollicis longus, and one should be make sure you are not going to disturb the paratinon of the EPL, and plate has to be strictly placed underneath the periosteum. So dissection should be very carefully performed without injuring the paratinon and getting the right placement of the plate at the base of the thumb. So as you are going to place it, the future function can be expected very well. Another example, which is extra-articular fracture, we have done the open reduction internal fixation by putting a Y kind of plate and function at the end of the 3 years period. Here the patient came here with the where we have got a functional outcome at the time of the implant removal. Usually implant removal is not routinely indicated, but if the patient is asking, this is one of the cause for the implant removal. The Bennett fractures are the intra-articular fractures, which is different than the extra-articular fractures. The open reduction is one of the paramount for such kind of fracture. Closed reduction with the K-wire fixation can be tried, but sometimes when there is a significant displacement of intra-articular fractures, the significant angulation is there, the open reduction may be indicated. The impacted fracture is definitely a important thing for the open reduction. The most common complication is stiffness, epiphyseal growth arrest in the immature skeleton. Avascular necrosis if the fragment size is very small, and there is always a possibility of the injury to the superficial branch of the radial nerve if you are not going to dissect out very carefully. There may be malunion, persistent subluxation, painful carpometacarpal arthritis. I will show some of the examples here, like one of the patients who came with a painful thumb with a malunited basal fracture of the thumb. Here we have done open reduction, did an intra-articular osteotomy, and after doing the osteotomy was fixed in a proper position with a all alignment of the basal fractures here. Once you are going to realign it, the mechanical axis is well maintained, and hopefully the patient is going to behave in a proper way in the coming future. Another condition with a fracture of the base of the metacarpal with a significant carpometacarpal osteoarthrosis. We have done the fixation for the fracture by using a plate and a screw around it, and the arthritis was taken care by half FCR interposition in between the carpal and metacarpal. The patient was having a deformity in the post-operative period, but was having a painless, good functional outcome at the end of the day. So it's a fairly reliable technique. It follows the basic principles of the fracture fixation, reduce radiation, then the closed techniques. Early motion is the key of success. Thank you very much. The one thing is very, very important. One should be very careful at the time of dissection of the tendons around the metacarpal and phalanges. One should take care for the paratenon and try to put the plate strictly in the subperiosteally. Then only you are going to get a good function. If you are going to injure it at all, try to repair it back with the thin sutures.